Welcome back. This is part two of behavioral based emergencies. And I've got Jeff Bell here with me again. Jeff, quick, do you want to talk a little bit more about your mental health training and where you kind of specialized in?
Absolutely, yeah. So again, I'm very very grateful to be here and talking with you guys. So a little bit of background. So I've been a paramedic now since 2009. So going on 13, 14 years. And did my advanced care in 2015 in Winnipeg. I found throughout my career that we as paramedics, regardless of training level, are solely ill-equipped, sorely ill-equipped to deal with mental health emergencies and a lot of social emergencies, which do command a large percentage of our call volume.
Yeah.
In 2016 or almost 2017, I went back, completed some social courses through University of Manitoba, and began practicing as a youth addictions counselor. Just because I wanted to get more information on how I could be more effective in treating patients and mental health and social emergencies in the field. I operated in that capacity for roughly 2 years, and now I'm operating as a paramedic specialist up in the Yukon here. So very excited to be working with communities in talking to you guys about this and getting us all more equipped and more readily equipped to deal with these kind of emergencies.
Do you find that that background has helped you as a paramedic specialist dealing with the population that you're dealing with?
Oh, absolutely. And I think that comes down to, again, how we determine what is an emergency, right? Is it a traumatic event? Say somebody gets hit by a car, is that an emergency? Well, of course, right? Or if somebody's got, like a bad asthma attack, well, that's, of course, an emergency, right? But what about somebody who has no home, that has no money, that spent every dollar that they've had on this drug of choice, that they're now contemplating ending their life. They have no supports in place, and they're alone out there, right? So, is that an emergency? Absolutely, it's an emergency,
Yeah.
right? And where are we as healthcare providers? And so, we're supposed to be experts in this field. Where are we equipped to deal with that? We're not, right?
No.
So coming up here and operating in this role, becoming intimately familiar with the territorial services that are available or not available, right, on the flip side, and being able to not just deal with the acute incident, the acute emergency, but then to be able to properly refer people to patients to services that will assist them in the needs, which are far greater than we can meet in the short time that we're with them.
Yeah. Well, that feeds a lot into the next section, which is addictions. Substance related disorders is the way that the book puts it. And I feel based on your expertise, that's why I asked you to talk on this, and I'm assuming why you agreed.
Yeah.
What can you tell us about substance-based disorders and how we can treat them pre-hospitally, especially in the communities?
No, that's a great question, Ryan. So, as pre-hospital care providers, right, the initial thing that we have to assess is obviously if there's anything at risk to the person's life, right, and where they're at. We want to look at the picture as where a person lands when it comes to determinants of health, and I'll speak on that a little bit, right? The determinants of health are things like where is their shelter, right? Do they have adequate shelter, and is it safe where they stay, right? Another determinant of health is finances, right? Do they have a job, or do they have any form of income, right? Another determinant of health is spiritual needs, right? Or whether that's cultural needs or religious needs. And another one is social needs, right? Do they have healthy supports or healthy connections, right? And when you tie this all into addiction, it gives you a really detailed picture as to how well the person is functioning in their current life. So in the communities, obviously we have a lack of resources, right? So that makes this role, the role of the pre-hospital care provider, of the local EMR, that much more relevant, that much more prominent, right?
So, Jeff, we deal with a lot of people who are having effects of addictions. Can you tell us more about addictions in general?
Absolutely. So addictions is one of those things where as soon as we hear it, we generally hear alcohol or drugs. And even that in itself is interesting because alcohol and drugs shouldn't be separate because addiction is addiction is addiction.
Yeah.
Alcohol is a drug, right?
Yeah.
And it's interesting, I'll touch on this too because this is the start of this explanation is when people talk about cocaine addiction, right? Well, are they a cocaineaholic then? Why is it just specific with alcohol that you're an alcoholic, right? Old school thought is that alcohol is separate from drugs, from recreational drugs. It is not.
Is that primarily a judicial thought process?
It's, you know what, I think it's just it's a grammatical, norm that started, I was back in, I think, the 1920s that like AA was formed, and they really focused heavy on the alcoholism, right?
Okay.
The person whose life has been just overtaken by alcohol. But if you want to look at the actual biology, the physiology behind it is addiction is addiction is addiction is addiction, and that's what I mean. That it doesn't matter what it is; it's the same process in your brain, the same reward process, right? The same reward cycle. So when we talk about addiction, we have to first understand that addiction could be to anything. It doesn't have to be drugs, which includes alcohol, right? It can be shopping, it can be sex, it can be porn, it can be eating, it can be Netflix, it can be a cell phone. All of these things have the same process, except they act a little bit differently, where now a cell phone does have the ability to become a negative, like it can impact your quality of life if you're using it too much.
Right.
But if you're out there smoking crack cocaine, it's going to impact it more than likely much more rapid than say an eating addiction would. Right.
Okay.
Some things happen a little bit more slowly. Some things happen more fast, or progress a little bit more rapidly. Another way to easily relate that is that even in the addiction process itself, you have what you would consider as like a rapid addiction process, where it's this individual, say, finds this drug of choice, and their entire life is forever changed within the span of months, right? Or you have another individual that drinks 24 beers a night, but he's still got a job and he still takes care of his family to a degree, right? And this is where they use a term called functioning. I'm sure you've heard the term functioning addict, right?
Yeah.
Completely wrong term to use.
Okay.
There's no such thing as a functioning addict because it's always on a decline. It just depends on how big the decline is, right? Whether it's over the span of 20 years or 30 years, or whether it's over the span of 2 or 3 months, right?
Okay.
So you can have somebody that rapidly destroys their life, focused around addiction, or you can have somebody that it's a slow burn. To put it lightly, it's a slow burn. When we encounter patients who are suffering from addiction, the first thing that we do that we need to be aware of is that they know in 99.9% of the cases that they have an addiction problem. Right?
Okay.
Whether they're open to talking about it or not is a different thing, but it is not our position to sit there and go like, oh, I think you may have an addiction problem, because the reality is this person has probably thought about it countless times before, and they don't want to sit there and hear somebody lecture them on their questionable life decisions, we'll say, or alternative life decisions, right?
Okay.
So
enough.
focusing on like a non-biased approach, a non-judgmental approach, right? And really just being open to listen, right? And be an active listener. Things that we as providers have to be aware of is a thing called change talk. And change talk is where, I guess I'll focus back to addiction medicine and how this is a little bit frustrating for providers, where in addictions medicine, we can only help an individual as much as they want to help themselves. We can open all of the doors, and as you say, you can lead a horse to water, you can't force it to drink, right? change talk is very important because it's the patient themselves or the individual themselves talking about how they might want to change their life. They might want to live a different way. Because there's this common misconception that, oh, that person's living on the street or they're living in this squalor. There's no way they like living that way. Wrong. Some people do like living that way, and that's their choice, and we have to respect it, right? Mm-hmm. However, there is change talk, and change talk is where a person is considering to cease use, right? To stop their use, right? Things to consider in times like this is like, what social services might you have available, right? What sort of counseling services you have locally? Where might you have to reach outwards geographically to find adequate social services that focus specifically on the patient and their needs? Looking at asking the patient if they've gone to previous treatments, right? What have they done that's ever helped them in the past, such as 12-step programs like Alcoholics Anonymous, CA, which is Cocaine Anonymous, NA, which is Narcotics Anonymous, CMA, which is Crystal Meth Anonymous, or GA, which is Gamblers Anonymous, and then there's also SAA, which is Sex Addicts Anonymous.
I did not know there were so many of them.
Yeah, there's all those 12-step programs, right? And then those are all very spiritual based, but then there's also things like secular programs called like SOS, which is Secular Organizations for Sobriety. And that focuses less on the spiritual side of things for people that don't really want to grasp the whole power greater than themselves. They want to focus more on like the decision-making side of it.
Okay.
There's support groups such as Recovery Dharma. There's Buddhist related. You could find recovery groups that match every situation, and in every situation, they can differ. We live in 2023.
Yeah.
Most places have internet access, and even if you don't have internet access, you can find some free public Wi-Fi, and there is the ability to connect with these groups across the world.
Virtually.
Every day, right? So even in trying situations such as the remoteness of Yukon communities, you can reassure that person that they do have the ability to connect.
Okay.
If they A, want to, and B, if they have the ability to somehow get internet access. Common uses, like common substance uses in the Yukon here, I think we use the top three, which is crack cocaine, opiates, and alcohol. We'll talk a little bit about all three. Crack cocaine obviously being inhaled. Chemically, the exact same thing as powder cocaine. It's just cooked with a buffer, which is sodium bicarbonate or baking soda.
Okay.
Super short acting, but very high. Very very significant peak in the high, but very short acting. Right. So this is something that the person's going to be presenting as like a stimulant overload kind of thing. So they're going to be tachypnic, right? They're going to be tachycardic. They're going to have high blood pressure, all those things you would you would find with a stimulant.
Most of the patients that I've had call me because of crack cocaine usage are patients who are having some sort of cardiac issue. They're feeling chest pain. They're feeling palpitations. Those are the things that they typically get scared of.
Yeah, and rightfully so. I mean, if you look clinically, right, Prinzmental angina, right, which is a coronary artery vasospasm, right, it has the exact same pathology as a myocardial infarction with an occlusion, like a thrombus or an emboli, but there's no fix to it.
Yeah,
because it's just that artery just spasming away, right? So,
and that being said, for our purposes pre-hospitally, if someone's complaining of chest pain, we're going to treat them using the chest pain algorithm.
Absolutely. Yeah, and the thing was with crack cocaine, even after days of use, cocaine has this really, it is a fantastic quality where you don't actually have a physical dependency. Cocaine is primarily all psychological. So you can use it for days on end, and you're not going to suffer from that physical withdrawal, right? And that leads us into our next drug, which is opiates, right? So opiates are anything related to heroin, essentially, right?
Yeah.
Anything that activates your opiate receptors. So that's your codeine, that's your oxycodone, right? That's your hydromorph, that's your fentanyl, right? That's your morphine.
Yeah.
All of those things are within the same class, right? And a lot of them actually chemically convert into morphine in the liver.
Eventually.
Eventually into
Yeah.
morphine, right? Now, opiates are very different from stimulants because they you form a dependency on them where you need to take a certain amount every day just to function, just to be a baseline, right?
Yeah.
And if you don't get that, then you get what's called dope sick, right? Which is where, go ahead, Ron.
And that goes up, right? The amount that you need to get that
Absolutely,
baseline
it
goes
only trends
over
up. It
time.
only trends
Yeah.
up over time. So with opiates, the longer you're on it, the longer you're taking it. Like to put this into comparable terms here. So clinically, the strongest I've ever seen, like the most morphine I've ever had a patient on daily was 850 milligrams.
Which is insane.
Yeah, because what's the therapeutic dose in the emergency department for morphine?
5 to 10 milligrams.
5 to 10 milligrams. And this individual was on 850 a day, right? Because they had been on opiates for 30 years.
Yeah.
Now, the thing is with opiate withdrawals, right, or say like, the person can't get their drugs or they don't get the drugs, they're going to become sick and violently sick, right? They're going to essentially feel like they're dying, right? They're going to have diarrhea, they're going to have sweats, they're going to have pains, they're going to have aches. But the key to take away from all of this is that regardless of the level of dependency that a person has on opiates, it is not fatal. The withdrawal process is not fatal. It can be managed with benzodiazepines and things of that nature, but it's not fatal, right? Mm. The patient would have you think otherwise, but it itself is not fatal.
Everyone I've talked to who's gone through that said it was the worst thing they've ever done.
Absolutely, but it's probably the best thing they've ever done, right?
Yeah.
Because they fought through it, right?
Yeah.
And then a time frame when you're coming off of opiates, especially if you're a daily user, you're looking at like 1 to 2 weeks. 1 to 2 weeks guaranteed of feeling some form of withdrawals before you can kind of progress to getting back to a level of normalcy. And then we come to alcohol, right? Alcohol is, as far as I'm concerned, alcohol is the most destructive force in the galaxy. It is easily accessible. It's legal.
It's relatively easy to make on your own.
It's easy to make on your own, exactly. And it can kill you. Not just the use, but the withdrawals. So there is only 2 substance withdrawals out there that will reflect with a fatal outcome or potentially fatal outcome if you had a high enough dependency to, and that is alcohol and benzodiazepines. And when I mean benzodiazepines, I'm talking about your lorazepam, which is your Ativan, right? Your Valium, which is your diazepam, triazolam, nitrazepam, temazepam, which is Restoril, alprazolam, which is Xanax. All of those medications, when taken regularly over a long period of time, that acute cessation can cause withdrawal seizures and kill you. So
and a lot of patients, when they do finally make that decision to stop, they will try to do it cold turkey a lot of times.
Absolutely,
and a lot of times, and I don't know the psychology behind this, but they'll try to do it on their own, and that's when it becomes dangerous for them. And a lot of times, that's when we get called in. So that's when we're going to intervene many times.
Absolutely. Yeah, and I'll back it up a bit too to talk about even with we touched about when we were talking about opiates, right, and how with opiate withdrawal, the patient might feel like they're dying, right, and there are, because of the severity in how they feel, the degree of how they feel poor, or I should put this, they feel so bad that there are opiate replacement therapies, right, that are put into place. Methadone is one, right? Oh. Methadone in itself is actually a very potent opiate itself, but it's very long acting, right? And you can titrate that dose, meaning you can lower that dose over long periods of time until the patient's essentially off of it, right? Suboxone is another one. Suboxone is a very safe medication. It's actually half buprenorphine, which is, again, a very potent, long-acting opiate. It's like a morphine derivative.
Yeah.
And then it's actually half naloxone, which is Narcan. So Suboxone is 50% buprenorphine and 50% naloxone.
Interesting.
Yeah, which is interesting because you have an opiate working against itself, kind of in the same pill. But what that's doing is it's also reducing the effect of the opiate, and it's creating a safer metabolic situation where if a person were to use street drugs from that point, they have that protection already.
Interesting.
Yeah. And then the third is Sublocade, which is an injection.
Okay.
I've
never heard of that one.
Yeah. So there's those are the big three: Suboxone, Sublocade, and methadone. When it comes to alcohol and benzos, though, it's not; those aren't things that when you have a high enough tolerance that you can actually stop acutely and then not follow it up with definitive, like, observed medical care.
Right.
So in situations where if you have a patient who's been, say, drinking, and this is not out of the ballpark, like two sixes a day, or like a 40 or two a day, you want to encourage them not to stop.
Yes.
Right away.
I've done that actually.
Yeah. You and that seems counteractive.
Yeah.
But it's not, because you're preventing a further potentially lethal episode.
I never learned that in school.
No.
It was something I picked up on the street, essentially, through the years that I've been doing this. I started in 2003, and initially they don't teach you that.
No, they don't. No.
And it's very important to encourage patients to get proper monitoring.
Absolutely.
And to have that titration or the medical. There's medication you can give them to get them past that if they do decide to go to cold turkey.
True. So let's focus with the communities, right? Which is why we're here today, right?
Yeah.
So what can we do in the communities that would not only act within the patient's best interests, right, but give them the best possible outcome when suffering from an addiction-related crisis?
I think that the supports in every community are so varied.
Absolutely, I couldn't agree more. Yeah.
I couldn't even speak to a specific community at this point. It's going to be incumbent on the individual responder to learn what's available in their community, so they can help with that. But working with the community nursing is going to be huge.
Absolutely, I couldn't. Yeah, that was a great point, Ryan. Like, with the EMR position in our remote communities, right, and how prominent that role is, how important that role is in these rural communities, right, it is within that provider's best interest to become familiar with what is the possibilities of care, right, which support groups are possible, which are not possible, right. I mean, and again, that varies from community to community, right. When you have a patient who meets the criteria, so let's say you've done your due diligence, you've gotten the best picture of the current circumstances that you can to give to the nurse, right? So, like, we'll say frequency of use, amount of use, lack of social services or social supports. We talked about the determinants of health, right? Does the person have any income? Do they have any shelter? Is there any risks? You know what I mean? You factor all of those things in, and then to go to the nursing staff, right, your local nursing staff, and try to determine what the best route of action is for that patient, whether it's transportation to transportation to Whitehorse, where a patient can seek monitored detox and chemical withdrawal services, and then direct admission into residential treatment, right? So in Whitehorse here, we not only have a medically observed chemical detox facility, we also have a residential inpatient treatment program,
right?
And then, in a person's best interest, actually from the cascade, the three best decisions you can possibly make in that recovery process is, first, the initial identification, right, where change stock is being made, and detox has been chosen. And then after indeterminate stay in detox, right, transition directly into a residential treatment program, right, and then from the residential treatment program directly into what they call second stage housing, which is high barrier, housing in the community or communities where one or more people with the same goal of sobriety and recovery live together and are held accountable by drug testing and by breathalyzing. And they can stay in this housing for an indeterminate amount of time until they branch off and build a solid enough foundation to basically, project a more healthy lifestyle.
How much that is available in the Yukon?
Almost zero, almost zero, and that's the unfortunate but very real statistic. So in the Yukon right now, we have zero second stage housing.
Okay.
So that's something that I know that I'm working with CYFN and trying to maybe get something going, because right now the only options that we really have is sending people out of territory, right? And the thing is with addiction, and what makes it so frustrating from addictions medicine perspective is a person's brain, a patient's brain, an addict's brain, whatever, right? Their brain recovers about 50 to 55% of their baseline function, like pre-addiction function,
Okay.
after 90 to 100 days abstinence. So 90 to 100 days.
Right.
So even if we just go about the process that we just talked about from the initial detox to the treatment up here is in Spruce program is 42 days, right?
Okay.
So you add on, say, maybe 10 days for detox and then 42 days there, you're only at 52 days
Yeah.
before it's, back home or back wherever, right? And if you're not returning to a supportive environment, the chances of success are astronomically low. And that's an unfortunate thing, is that when we look at the statistics, and why is this such an epidemic? Why is this so important? Because when we look at Canada as a whole,
Yeah.
and the amount of addicts, active addicts we have in Canada, there's roughly 6 million, 6 to 7 million, Canadians in active addiction, right? And of that 6 to 7 million, only 6% is projected. That's a global empirical statistic. 6% of people suffering from active addiction actually recover to like lifelong abstinence. Now, I have a problem with that number because it doesn't really talk about who jumps in and jumps out of treatment, and that's only reported data. But it's definitely an uphill battle. So, the first thing that we can all do as residents of this territory and wanting to bring the highest level of care possible up here is to advocate for our patients to seek that higher level of care wherever it may be,
Okay.
even if it's outside of territory, because we don't have the resources, especially outside of Whitehorse, to really even hit the benchmark that we're trying to hit nationally.
I've definitely encouraged a lot of patients who were interested in getting out of their addiction to go somewhere else.
Absolutely.
And it's hard, right? They've got their friends, their family here a lot of times. Sometimes it's they're in housing that may be free or very cheap, and the idea of transferring all of that away from the Yukon for an unknown period of time, right? I guess you're talking this could take a year, 2 years before they're fully functioning again, right? That's a daunting task.
Yeah, absolutely it is. But it's something that's so necessary. I mean, if you look at just the Yukon as a whole right now is in an opioid epidemic. That's what they're classifying this as.
Right.
And in the Yukon, we have the highest addiction rates per capita in Canada.
Our alcohol consumption rates are the highest per capita.
So how do we have a population that is suffering, but we have none of the resources that are needed to? I'm not even going to say rectify the issue. I'm going to say just to suppress a little bit of the outcome, right?
Yeah.
It's challenging when you think about it, right? But back to we as providers.
Yeah,
Phil.
no, and I was going to say, you were talking about, in the communities, once they get to the healthcare center, the Whitehorse might be where they end up. The thing to remember is that the health center can only take care of a patient for a certain period of time. I think it's about 4 hours.
Absolutely.
And after that, the next step is to get them to Whitehorse. And so most people who go in with withdrawals will typically end up in Whitehorse.
Yes, and that's good. I understand, it's challenging leaving their home community and their family and things like that. But in times where, if you remember when I mentioned change talk, right, or to talk of seeking help, this is a time when the patient themselves, the addict, has to be selfishly healthy in making their decisions, right, where they have to make decisions for themselves and seek that level of care, because at the end of the day, unchecked addiction leads to generally incarceration or death.
Yeah.
And that's unfortunately the proven statistic is unchecked addiction leads to that.
So how do we as practitioners approach these patients? They've called 911 or someone's called for them because they see them on the side of the road or on a park bench somewhere. How do we approach these patients?
So, I mean, I would encourage approaching them just like you would approach anybody else, right? It's hey, how's it going? Somebody called, they were concerned. It's being non-judgmental and unbiased and open and ready to listen, right?
I'm going to admit, for me, having seen a lot of these patients so often, that's difficult. I go in with a lot of what our chronic users and be like, all right, Bob, what is it this time?
Yeah, absolutely.
How does that change the dynamic of treatment and our what kind of reaction we're going to get from the patient?
I think, in Brian, that's a very good point. See, when we're only human, right? And if we don't want to presume to know what we're going to, or to know the complaint or the actual issue, right? But 8 out of 10 times we're proving ourselves correct, right? It's only natural to look at something from a skewed angle, right?
Yeah.
Remaining vigilant and inquisitive in even repeat situations is hard, right? As practitioners, but it's so necessary, because it's when we become complacent that we miss things. That's where we miss the big red flag that we're not looking at, because we've dealt with, like you said, Bob, 6 times in the last week, or maybe twice and 3 times in the same day, right?
Yeah.
Now, yeah, that's the easiest way to summarize that, and it's the provider has to be able to forgive themselves, or cut themselves some slack when they're getting emotionally exhausted, because that's what it is. It's emotional exhaustion,
Right.
when you're dealing with the same thing again and again and again, right? I would always venture to say that, if you feel that way about the situation, imagine how they feel.
Yeah, that's fair.
You know what I mean? And it's that's something that works for me. I also, know firsthand, having some family for many decades that went through horrifying, addiction, family destructive addiction, right? That these are all people, much like me or you, and I think the reality is that we have to understand that anybody walking around is only a few bad decisions away from being in that exact same position, right? A lot of people suffering in these circles didn't have a chance, as far as I'm concerned. There was never a supportive environment. There was never the ability to walk away and say no. There was, you know what I mean? They were never given the tools to succeed from the start. So who are we to walk in there and start getting frustrated with, why isn't this happening? Why isn't this person doing this? Kind of thing. There's much more deeper. There's a deeper rooted issue here, right? Mm-hmm. And part of solving this issue up here is not solving it, but part of assisting in solving the issue, which is what we should all be shooting for, is accessibility, right? And we'll circle back to responders in the community. Why is it so important? Why is this role so important? Why are we talking so heavily about this? because we are always accessible.
Yeah.
Right? We are that always we're always accessible. We may not be the best resource, but we're always accessible, sorry.
Yeah.
And that in itself makes us confront a lot of situations that we may not be, in tune for, right? Or may not be specialized in.
Yeah.
But it creates a situation where maybe we should take more onus on what we know and what we can deal with, and that's just my thoughts.
That makes sense. So we approach Bob. Bob's my generic term for
Yeah,
everybody.
okay, Bob. Yeah.
We approach Bob with our open, unbiased, non-judgmental approach. What are some key questions we need to ask Bob?
Well, how about, just simple things like how he's feeling today, you know what I mean? And how did he get to where Bob is,
Mm-hmm.
What has Bob done recently to help his current situation, right? Maybe something else has gone on in Bob's life, right? You ask Bob how his supports have been, how his social supports. Ask Bob how work has been, right? You take away a lot of the generic medical questioning, like a lot of the pertinent negative questioning, and focus it more heavily on the social aspect of, like, one could even look at their own life and go, what makes my life tick? I'm going to ask those questions to this person, right?
Okay. Yeah.
Money, shelter, what's going on today? Obviously, gauging a level of intoxication is important.
Yeah.
Right? Because depending on how intoxicated a person may or may not be, dictates how receptive they may be to what's going on, right?
Yeah.
And that's another key thing we can take away from this is assuming intoxication levels. Can never assume intoxication levels. You can have people that are intoxicated but not impaired, right? You can have people, or impaired but not intoxicated.
Yeah.
You know what I mean? You can have people with slurred speech and
it's impaired but not intoxicated.
Impaired but not intoxicated. You can have people with slurred speech and a staggered gait that know their person, place, time, and event.
One of the most interesting things I found is that when I ask people how much have you had to drink today, specifically addicts, or how much drugs have you taken today, 90% of the time they will just straight up tell you.
100%. Yeah.
I've had 2 40s. Did you drink those all by yourself? Well, one of them I had some friends help me with.
Absolutely.
And, okay, what's normal for you? Do you always drink 2 40s a day?
Exactly right.
Actually, normally I drink 3.
Yeah.
Okay, so you're under medicated?
Under self-medicated.
Under self-medicated.
Is that a money issue?
Yeah.
Why is there a deviation from it, right?
Yeah.
And again, it comes to all of this questioning comes to forming the best picture that you can give, again, to that nurse that you'll be handing off care to, right? And at the end of the day, with every patient that we're encountering, we're never deviating from territorial guidelines, right? Which is, if there's a presenting issue, we investigate and we treat it appropriately, right? And at the end of the day, you're asking the person, do they want help?
Yeah.
Do you want to go dry out for a bit? Do you want to go sleep it off somewhere? Like, give them the opportunity, leave the direction of their care, where applicable, in their hands. When I find when a person has more control over the direction of their care, you're generally going to end up with a positive result or a more positive result.
Okay, so now we've approached Bob. We've asked him some of our important questions in this case. What are some important assessments that we need to do on patients with addictions?
Excellent. Well, I think, starting from the top, right? Learning-oriented times 4, which is person, place, time, and event. The GCS scale is another easy thing. So Glasgow Coma scale, right?
Yep.
Determine if they're a 15, right? Because if you're dealing with somebody that is anything less than a 15, then it kind of complicates how you can leave somebody, right?
Yeah, no, fair enough.
When you're suffering from addiction, you can be in various states of intoxication, right? Some of which we can leave, and some of which we can't.
Right.
baseline vital signs are always a good indication. Make sure that they're of sound hemodynamic status, right? So blood pressures within normal ranges, heart rates within normal ranges, saturations within normal ranges, right? And then you can ask them if there's any other complaints that they have. If
Glucose?
glucose, absolutely, right. I almost forgot that one. Yeah.
Okay.
So anytime, and this is good practice. Good practice is, and this is I learned this many years ago, is when you're dealing with any impairments, get a glucose. Yeah, get a glucose on them. Right. Ensure that that's between that 3.9 to 6.1 value, because there are other medical conditions that may present as intoxicated, right, or that as if there's a substance on board.
Yeah.
And aside from that, it's basically it's supportive care, right? Complaint specific. If there's a specific complaint, you treat that complaint. Otherwise, it's supportive care. You can be more inclined to look into like gastrointestinal function, right? Chronic drinking, with causes gastric peptic ulcers. Forceful vomiting causes Mallory-Weiss tears. So there could be some presence of blood in the emesis. That's pretty much it. You want basically, and we talked about with the withdrawals, right? You want to gauge the quantity and frequency of use so that you can provide the best picture to definitive care on how to handle the detox or the downward trend, right? Has the person ever suffered from withdrawal seizures before, right? When was the common question would be when was their last drink, or when was their last use? How did they use it? How much did they use?
Yeah.
So
one thing with the opioids, I learned this the hard way, which is the sucky way to learn things. But if you give if you give a patient who is alert and oriented and on opioids, Narcan, it's terrible for them.
Absolutely.
When we give Narcan, according to our protocols, we give Narcan with a patient who has respiratory depression and an altered mental status. So, but once we give them that Narcan, they wake up. What should we expect?
Well, so the pharmacokinetics, inside the brain there, and the dynamics is it's a complete reversal, right? It's not just a blockade; it's a reversal.
Right.
It's an antagonist, right? So any baseline high or substance levels that they had is now zero if the dose is high enough, right? So you've now, even if done correctly, you've now pushed a person from therapeutic levels, like self-therapeutic levels of opiates, to a complete withdrawal, right? So things like hyperemesis or projectile vomiting, severe tremors, sweats, even like a baseline alteration of LOC.
Yeah.
You push them into this extreme, right? Which is what we try to avoid, because if you push somebody into that extreme, you have to further medicate them to bring them back into desired effect therapeutic levels, right? So that they're not in such active withdrawal. Luckily, specific to opiates, yes, you should always avoid that significant withdrawal, like over medicating with naloxone should always be avoided. Of course, that's hard to say, when we're speaking like this, because we're not on scene, we're not looking at the patient, we don't know what the clinical decision was and why the person made it.
Well, and at the EMR level, we're giving it the whole dose.
Yeah, so that's four. Yeah, so that's 4 milligrams.
Yeah.
4 milligrams of naloxone. So to put it in perspective, 4 milligrams of naloxone intranasally is a significant dose, and why is that? Because generally even with Narcan kits on the street, it's 0.4 milligrams intramuscularly, and then if we were to give it on in an IV, we could even further titrate it to a 0.1, 0.2 per dose to try to achieve that desired kind of return to level of consciousness, or at least improved respiratory drive. right?
Yeah, so we're gonna be hitting them hard, and they're gonna come out of it,
Absolutely.
and they're not gonna be super happy.
They're not going to be happy. I mean, you might have them come out swinging and very agitated because effectively what we've done is we've ruined their high.
Right.
We've ruined it, and not just ruined the high, but we've reversed any level of baseline, albeit like any baseline levels of opiates that they had on board. You know, so being aware of that's important. You know, but aside from that, and I would caution people on that. I would caution people, and again, it's up to the practitioner and the decisions they make independently. And I will always say that when in doubt, give it. Right? When in doubt, give it. That's the fallback, right? But when you have somebody who is, say, saturating with the normal ranges, may have a little bit of respiratory depression, right? Maybe nodding in and out, but otherwise vitally stable, I would encourage crews to make a more informed clinical decision than to just hammer them with a significant amount of Narcan.
Supportive care,
Support,
oxygen,
absolutely,
BVM
yeah.
if necessary. If you're giving a BVM with the guidelines the way that they are, we're going to be giving Narcan.
100%, absolutely. If you're having to assist respiration,
if you can keep them vitally stable with
if
oxygen,
say they're snoring away, and pressure's great, and SATs are say between 90 to 95, and
92 to 99.
Yeah, 92 to somewhere in that range.
The protocols.
Yeah, yeah, somewhere within that range. You know, you can have a patient that's much easier to care for.
Yeah.
You know, it's much harder to care for somebody who's acutely withdrawing than it is to have somebody who's drowsy. You know, yeah.
So transporting these patients, occasionally we're going to end up having to have our RCMP with us. That's
Absolutely.
just the way it is. Always remember to crew safety comes first. So be willing to get the RCMP involved if necessary. Sometimes they can cause more problems than they fix.
Mm-hmm.
Just their presence can sometimes, a lot of times, change the dynamics of the atmosphere.
Absolutely, and the substances that we're dealing with can acutely change the dynamics of the situation, right? So it's always, as Ryan said, and I can't support this enough. Like, when in doubt, involve RCMP, right? Because at the end of the day, you know, it's your safety and the safety of the patient you're looking after.
Yeah. Anything else you think is?
Not really.
Okay.
I think identifying situations where this is. I mean, the occurrence of this is so prevalent in our territory, right? So becoming keenly aware of what we're dealing with and how we can further improve the level of care that we give, becoming familiar with local services and local support groups, and really reducing the stigma around addiction, and treating, again, not the addict but the person behind that, because behind every addict is a person that puts their pants on one leg at a time, just like we do, right?
Yeah, that's good. So thank you for sitting down and talking with me. I really appreciate it.
Oh, no problem. It was a pleasure being here.
And hopefully everything works for you guys. Hopefully you learned something, and we'll see you again next time.
All right, sounds good.